The following podcast is part of a certified educational activity titled The LEAD Initiative, Clearing the Path to a Clinical and Neuropathological Diagnosis of Early Symptomatic Alzheimer's Disease in an Academic Center. Launchpad to Excellence in Alzheimer's Disease, a quality improvement project. Access the entire activity and complete the post-test at peerview.com/RTX860. Downloadable slides and practice aids are also available.
Hello and welcome to the LEAD Initiative. This initiative is clearing the path to a clinical and neuropathological diagnosis of early symptomatic Alzheimer's disease in an academic center. This is really meant to be a launchpad to excellence in Alzheimer's disease. I'm Jared Brosh, an associate professor of neurology at Indiana University, and I'm here to help introduce you to this LEAD initiative. Our goals for today are to enhance your understanding of recent advances that have been made in Alzheimer's disease diagnosis and treatment that may lead to improved patient outcomes. You're also going to hear about increasing your awareness of opportunities for process and workflow improvements in a healthcare system to provide optimal care to patients with symptoms of cognitive impairment or suspected Alzheimer's. You're also going to hear about how to improve your ability to implement quality improvement methods and improve the timely and accurate diagnosis and treatment of early symptomatic Alzheimer's disease. So for our first module, we're going to be talking about translating advances in Alzheimer's disease research into improved patient care. So the first question is, who should be evaluated for cognitive impairment? Certainly, any individual that comes into your practice that has a complaint about having a problem, either from that patient themselves or from a close contact of that patient, this would be an ideal person to take the next steps. In addition to that, when a person comes in for an annual wellness visit through Medicare or otherwise, an assessment of cognitive function is important and a part of many of those visits. And these can be accomplished through a variety of different tools, but we know that doing a cognitive assessment of some sort is better than simply observing that patient for cognitive deficits. We should definitely consider hearing and vision screening and understanding how that might impact a person's cognitive functioning. And whenever possible, we want to capture what families and informants have to say. The Alzheimer's Association has created recommendations for primary care and general specialty care with 7 core elements of evaluating a patient with cognitive impairment, and this involves goals, history, systems reviews, looking at medications, cognitive evaluations. But I wanted to really look at in more detail a little bit about what this looks like when we try to integrate all of that information together. Ultimately, if we look at step 6, when we want to integrate information from everything, we're looking really for 3 key elements. The first element is, what is the level of that person's cognitive functional status? Is this someone who has normal cognitive abilities? Is this someone who complains about their cognitive functioning but has a normal evaluation? Someone who has some cognitive impairment but is functionally independent, also known as mild cognitive impairment? Or does this person have some degree of dementia with limited functional abilities? Secondly, we want to understand what cognitive behavioral domains are affected. Is this an amnestic syndrome, one that we might see more commonly in Alzheimer's disease? Does this person have more of an aphasic, a language-based presentation, a behavioral or executive presentation, a visuospatial presentation? This type of descriptors can help us form a better diagnosis. And then finally, whenever possible, we want to give an etiology for what disease state might be causing this person's cognitive and functional decline. Biomarker testing can be helpful in establishing a final diagnosis. Who is the most appropriate person for biomarker testing? We know it's a person that has some objective evidence of cognitive impairment. We do not recommend biomarker testing in individuals who are not cognitively impaired, as this might lead to additional concern, worry, stress, and at this time there are no approved treatments and minimal, if any, clinical trials available for individuals in that population. If Alzheimer's disease is felt to be a potential cause for cognitive impairment, and we think that biomarker testing is going to help improve the accuracy of that diagnosis or help them reach treatments that they wouldn't have found otherwise, we think biomarker testing is a good option. As an example, if someone comes in with moderate or severe dementia that you're evaluating, the biomarkers may not add significantly to this patient at all. So considering each individual person and whether those biomarkers make an impact is important. There are a variety of biomarkers available, and in this revised 2024 biomarker categories reference here, we can see that there are not only a wide variety that are available, but some that are available in research as well. Generally speaking, we try and establish a ATN diagnosis for Alzheimer's disease. So we're looking for some measurement of amyloid, some measurement of tau, and those abnormal tau species we call phosphorylated tau specifically, and then some form of neurodegeneration. Certainly also of interest is vascular brain injury, whether or not a person has alpha-synuclein, as what is seen in any of the Parkinson's and Lewy body conditions as well. When we get an anatomical MRI scan, we're really seeing neurodegeneration only. We're looking at atrophy out of proportion to a person's aging process. When we get an FDG PET scan, we're really looking at metabolism of the brain. So this is only telling us about neurodegeneration. More specific biomarkers tell us about the presence of disease. And we break these biomarkers down into 3 categories that we can attain clinically speaking. PET scans, particularly amyloid PET, is the gold standard diagnosis for Alzheimer's disease. These PET scans show us the presence of amyloid plaque. One of the newest advantages of amyloid PET scans, and varies from region to region, is the ability to measure the degree of amyloid plaque that's present. This is typically done through SUVRs or centiloid values. This can be helpful in our understanding, as a very low centiloid value speaks against a diagnosis, a presence of amyloid, and very high values indicate a large amount of plaque that's present. This type of information can guide treatment. We may be able to stop amyloid-targeting therapies early for lower or medium values of centiloid, or we might decide that we need to continue therapy longer in individuals with high centiloid values. The disadvantages are that this is expensive. It's not readily available for people in all areas of our country. Spinal fluid is unique in that it gives us ATN with one test. In spinal fluid testing, we can measure levels of amyloid and amyloid ratios. We can measure levels of phosphorylated tau, and we can also measure neurodegeneration in the form of total tau. So that it is unique in that sense and generally felt to be equivalent in its accuracy to amyloid PET scans. The disadvantages, of course, are many practitioners are not comfortable with providing this procedure. There can be some difficulty in attaining it depending on where you're at in the country. It is more invasive, and there may be some contraindications and difficulties in terms of, say, things like anticoagulation, medically speaking, low platelet counts, or other complications, including lower back surgeries that might make the procedure more difficult. Blood-based biomarkers are the latest in terms of biomarker assessments of Alzheimer's disease. This is one of the simplest things that we can do, and all practitioners are very comfortable in ordering blood tests. In May of 2025, the first blood-based biomarker received FDA clearance. These biomarkers generally provide an assessment of amyloid and of phosphorylated tau, the biomarker that is seen primarily in Alzheimer's disease. The difficulties with these blood tests are they may not be available in all areas or easy to order in your EMR or through your lab. There is some variability in the accuracy of these tests, and this is something that's being borne out and published. These blood tests may also require some additional cost at this time, and currently there isn't a clear uh, consensus on what the reimbursement from Medicare might be like for these tests. There are also some individuals, particularly those individuals with chronic kidney disease, where these tests are less accurate. With this first FDA cleared blood test, you can see it has a very high positive predictive value and negative predictive value. There is also an indeterminate range where about 20% of individuals who are tested will need to have further testing to clarify the results. One thing that's also important, as we discussed before, is that this is not intended to be a screening test for asymptomatic individuals. It's currently not approved to be a standalone diagnostic test and needs to be interpreted in conjunction with other clinical patient information. There are several available blood tests in the United States. These individual tests all have variable amounts of negative predictive value and positive predictive value. Several of these tests are available in a widespread fashion and have different costs associated with them. In this list below, the LabCorp test is the LumaPulse test that we have discussed above and is most commonly ordered as a ratio as seen here. Next, we'll talk about disease-modifying treatments. Treatments have been around for quite some time, those treatments targeting amyloid. And we can see some of these early drugs on the bottom, solanezumab, gantenerumab, aducanumab. These drugs, unfortunately, were not successful and led to some additional controversy in the amyloid hypothesis. However, the latest FDA-approved drugs, which are clinically available, lecanemab and donanemab, have shown clinical benefit, which we will discuss. What's important to note is that these drugs all target a different spot in the amyloid pathology, some targeting very specifically the plaques and plaque only, and some of the drugs targeting different forms of amyloid that are more soluble, such as oligomers, protofibrils, and so forth. These individual targeting areas may have some impact on whether the drugs can be used longer term, as in maintenance therapy, or what their efficacy might be like in terms of plaque removal. Regardless, at this point, the two FDA-approved medications are the first disease-modifying therapies and have been shown to substantially lower amyloid plaque. These drugs take approximately 12 to 18 months before we see a substantial amount of complete plaque clearance. These drugs have been shown, depending on the scale that was used to measure their performance, somewhere between a 20 to 40% slowing of the clinical decline of the disease. So over the course of an 18-month treatment, which was the duration of the clinical trials, there was an approximate savings of about 5 to 7 months of expected decline. The question is whether that will be maintained over a longer course, and this is an area of great research interest at this time. Certainly, there are risks associated with amyloid-targeting therapies. The most primary ones would be some reaction to the infusion themselves, which are very common, and then the presence of amyloid-related imaging abnormalities. When we look at the performance of lecanemab, we saw very robust plaque clearance over 18 months, and then in the right-hand chart, using a clinical and functional score called the Clinical Dementia Rating Sum of Boxes score. This is not used clinically very often, but it is a combination of both functional ability and cognitive ability. This showed a 27% slowing with lecanemab over 18 months. With donanemab, we saw very robust plaque clearance over 12 to 18 months, and also we saw a significant impact on that CDR sum of boxes with a 29% slowing. Amyloid-related imaging abnormalities are typically broken down into two different forms, those with swelling, which we call ARIA-E or edema, or hemorrhage, which we call ARIA-H, and this is either microhemorrhage, superficial siderosis, or macrohemorrhages. The most important concept here is that amyloid plaques reside within the blood vessels of the brain in all individuals with Alzheimer's disease. Naturally occurring small microhemorrhages and small areas of edema occur in all patients with Alzheimer's disease. When we accelerate plaque removal using amyloid-targeting therapies, we can see additional areas of hemorrhage or edema. When we look at this table that looks at 3 major clinical trials that involve these 3 medications, 2 of which are still available on the market, if we look at the placebo column, we can see that in the placebo group, we have at least 10% ARIA in individuals who are not receiving any amyloid-targeting treatments. This reinforces the idea that these episodes of microhemorrhage or edema are a naturally occurring phenomenon due to the presence of amyloid plaque. When we use the treatments, we can see that we have an increase in the all amount of ARIA. The appropriate use recommendations are available. These are expert guidelines on the use of these 2 medications, which are readily available. But generally speaking, we want to include only individuals who have a diagnosis of mild cognitive impairment or mild dementia due to Alzheimer's disease. We have confirmed amyloid positivity with PET or CSF, and that these individuals are testing on a standard cognitive score in high ranges, showing only mild impairments overall. We must obtain APOE genotyping for all patients as the risk of amyloid-related imaging abnormalities goes up as we have more copies of E4 due once again to the presence of more plaques inside blood vessels of the brain. And we need to have very close surveillance with MRIs, and we need to have one within a year. There's a variety of exclusionary criteria here that are listed, and many of these contraindications involve findings on an MRI that might put us at higher risk for hemorrhage or edema, and the use of any medications that increase our bleeding risk overall. All right, and then stay tuned for our next module on applying quality improvement methods.
Hello, I'm Greg Pontone, and today I'm going to talk to you about Module 2, which is applying the quality improvement methods to close the gaps in care for patients with early Alzheimer's disease. So let me tell you a little bit about the University of Florida Health System. It is the most comprehensive academic medical center in the South. It has colleges of medicine, nursing, pharmacy, public health, and allied health professionals like dentistry and veterinary medicine, all on the same campus. It's responsible for over 5 million outpatient visits and about 123,000 inpatient hospital admissions every year. And it has over 32,000 faculty and staff, including 2,700 clinical faculty. So it's a big place. Now, if you look at the structure of the quality improvement program we rolled out here, you can see that it has 4 main steps. And this is the planning, which is identifying an area where improvement is needed or a gap, and then defining clear objectives to sort of address those gaps. And then the second step is to do. This is where you implement the intervention on a small scale, sort of on a pilot run, if you will, to collect data and then note any changes. So once you've got this pilot going, you want to go ahead and look at that data and then see what's worked and what didn't and why, and then act. So based on what you observe in this small rollout, let's say you did it in one clinic, you might want to refine the intervention and implement changes so that when you go to a broader scale, you've made improvements. And you just keep going through this cycle each time, making small tweaks and improvements in your process. Now, the elements of this quality improvement approach include a steering committee, and this is basically your leadership group that's charged with directing the operational focus of the project. And then there's training that'll be needed to provide the sort of clinical people the information they need to go forward with this change in operations. In terms of whether or not you do meetings in person or virtual. Really depends on how you're rolling this out. We have a large health system, so we found that virtual meetings, usually on a quarterly or more frequent basis, was helpful, so that you could do discussions about progress and adjustments that were needed. And then you're starting to re-engineer the care pathway through these meetings, and you're implementing changes in the processes and the infrastructure to support the new approach. And sometimes there's a need for technical assistance. And so you'd call in with the care team members following data reporting to see if anything needs to be changed. And then you need to see if it's going to be sustainable. So there's a system of audits and feedbacks where you can sort of check in throughout the quality improvement initiative to make changes. Now, in our particular case, where we were looking at the root causes of problems with diagnosing Alzheimer's and providing care for this population, we identified a number of gaps. And these included things like delayed identification of patients at high risk for Alzheimer's. And so a lot of times in our electronic health record, which is EPIC, we found that these were in unstructured notes so that they weren't readily searchable. So you couldn't just run a search for what you were looking for. It would, maybe be a comment in the middle of paragraph 3 in a note. And so we didn't have a standardized protocol for flagging at-risk patients. And sometimes not only do you need the statement of impairment, you need maybe a link to a lab test or some sort of brain imaging, and that just doesn't exist. And so we needed to find a way to better identify these high-risk patients. Inconsistent cognitive screening. There was no harmonization. We didn't have a standard protocol. Some people were using the mini mental status exam. Some people were using the Montreal Cognitive Assessment. Some people were doing their own sort of cognitive assessment that might not even be structured. Some people were using paper instruments that were never scanned in to the electronic health record. And so we needed to harmonize our system of screening. There was a lack of early referral infrastructure. So, okay, let's say you do find a way to identify a patient at risk. Where do you send them? Well, we did have a memory clinic at the time, but that was predominantly seeing people with dementia of different kinds. So we needed to have a specialized place to refer patients who had early signs of cognitive impairment, but weren't so impaired that they actually had dementia, because that's outside of the window for most of the new interventions we were chiefly concerned about supporting. And then a sort of global problem is that we had very limited support for patients and caregivers, especially in underserved populations. And so we had to find a better way to integrate community services into patient care planning. And so these were our gaps that we wanted the quality improvement initiative to address. And so why does it matter if patients receive an early and accurate diagnosis of Alzheimer's? Well, there's a couple of reasons for this. And so let me start with the early part. The early part is really important for these new potentially disease-modifying treatments. The evidence shows that if they're initiated when the disease is too advanced, they're probably not going to be efficacious. So you need to identify patients who either have no impairment or at most mild impairment by the time they're identified to be eligible. There's also new diagnostic tools. And so knowing when to use these tools. So there's lumbar puncture to get cerebral spinal fluid to test. There's amyloid PET scans to confirm that they have the disease of interest, Alzheimer's in this case. And now there's new blood-based biomarkers. In fact, one that's FDA approved, the p-tau217, that are all potentially new tools that people have to learn how to use and implement. And then we also want to be able to identify people early for new clinical trials, and maybe even talking about things like prevention of diseases like Alzheimer's, getting them before they do enough damage to cause impairment. And so early diagnosis is going to have a number of important outcomes, I think, for patients. And it's also going to let them participate more fully in their own care planning, because they're still going to have the cognitive capacity to make decisions, to make meaningful lifestyle changes when they can still potentially slow progression of the disease and manage their own symptoms. And so I think there's many reasons why we want to have this early diagnosis. And then accuracy is really important too, because many things can cause cognitive impairment, and you don't want to expose somebody to the risks of an Alzheimer's treatment if they don't actually have Alzheimer's. So you want to make sure that these are, very sensitive and specific diagnoses that you're delivering. And so what did we do? What were the interventions we used to close the gaps that I just mentioned? Well, one was the creation of a patient registry, and we did this in REDCap. This is a structured patient data system where we can put all the important data in one place so that we can track patients longitudinally from the time that they're ascertained as a potential case through treatment initiation and then other outcomes, and then look at trends in these data. It's really difficult to do that in the electronic health record for a number of reasons that I'll talk about soon. We had to develop a electronic health record based order set. So a lot of these new tests are difficult to order and then interpret. And so we have to have a standard operating procedure for when and how to order some of these things. And so that takes sort of a re-engineering of order sets within the EHR. And then we had to launch, like I said, a dedicated referral location. So our memory clinic really wasn't appropriate because this was treating people with more advanced disease. So we needed to have a mild cognitive impairment clinic that was specifically for these early stage patients. And then finally, we had to have a more coordinated system for supporting underserved patients and their caregivers. And so we now have a community outreach group that meets regularly to go out into communities and do education and other types of outreach. We have caregiver support groups and social work services that are now aimed specifically at these populations, which is a population that's much earlier in the process than the traditional dementia populations. We still support those, but this is an additional population that we're targeting. So why did we choose this REDCap over an electronic health record like Epic? Well, one is that the query, the ability to search, is more customizable. And so especially with this sort of being a new category of cognitive impairment, we really needed the ability to look for these people in a new way. And we needed to be able to track them longitudinally and then also generate different metrics quickly. And so, and it had to be HIPAA compliant. So REDCap fit all of these things. Could it be done in an electronic health record like Epic? Sure, but it's much more complicated. It's expensive. Oftentimes you have to pay their people to extract it for you. Sometimes their data requires transformation that can be problematic as well. You need certain permissions to extract data. And as I mentioned before, on the provider side, we're not necessarily inputting this in a way that's captured in a searchable way into the EHR. And so I think this is something to consider if you're thinking of doing a similar protocol for these new treatments and diagnostic strategies in early Alzheimer's. What are the sort of steps and decisions in developing this patient registry? Well, we need to decide what to capture. So really it was the inclusion criteria that we felt were going to be most relevant for populations at risk and then populations that might be amenable to these new therapies. So we needed to get the demographic information, screening results from cognitive screening. And then again, we needed to find a way to harmonize that if people were using different instruments. We needed to be able to aggregate in correlation with these screening results, the biomarkers and brain imaging data that we had, and then look at the diagnostic outcomes and time to treatment initiation. and then finding a way to give this feedback to the providers so that they could look at how they were doing as they implemented each one of these changes. And then ultimately, we also needed to let the referring sources see this data so that they knew if the referrals were on target or not. Now, implementing the electronic health record based order set, we had some challenges. So we're still working on this. There's also some difficulty capturing these test results that are required for screening appropriate candidates. As I mentioned, unless it's in a smart form, you're not going to be able to readily extract it from the electronic health record. So we're working on ways to get that into a form that can be searchable in the electronic health record. And then really we need to educate the providers on these screening tools, the referral processes, and how to sequence treatment. And so all of these things need to happen and then need to be coded in our electronic health record. Now, if you look at mild cognitive impairment clinic, one of the problems we had at our center was that we lost about 50% of our providers who were doing these amyloid targeting therapies in early 2024. So this sort of delayed the full launch of the clinic until the fall of 2024. And it's still continued to somewhat limit our capacity to manage the patient volume. In terms of operational barriers and diagnostic tools, we did have some delays in receiving results from the lumbar puncture and cerebral spinal fluid. We had problems with getting amyloid PET due to reimbursement and other logistical issues. And so all of this now, fortunately, is getting on track, but it slowed us down early on. But I think ultimately, if you look at the results here, we've had a number of successes. So if you look at the time before we started the quality improvement intervention to after, so pre and post, you can see we had an increase in referrals made to the mild cognitive impairment clinic from our primary care referral sources. So clearly the referring sources heard the message. And then if you look at patients who were referred who ended up actually being diagnosed with the condition of interest, you're seeing improvements on the average length of time between primary care visit or the referral center visit and then the diagnosis date. So what are the results here? We had some good news along the way. So amyloid PET, like I mentioned, there was some problems with reimbursement that was addressed as of March 2025. So now we're able to order those more reliably. We're getting CSF testing results back more quickly. And now there's a recently approved, FDA-approved blood-based biomarker, the p-tau 2017, that I think is going to improve patient access. It's a less expensive test and more accessible in many centers. I think we have some good internal dashboards now where we're tracking data that's useful both to referral sources and for our providers in terms of meeting these outcomes. And so that was an important step. And then we've had 2 new providers join our MCI clinic, so that should improve capacity. And so if you look at where we are now and where how far we've come, you can see that there's a number of improvements in workflow. So a lot of the diagnostic technologies are now better established, and we're better able to access them and then also get them reimbursed on the patient side. I think you can see that our work on the referral sources in the primary care setting absolutely yielded a big outcome, both in terms of number of referrals, but also the positive predictive value of those referrals, meaning that these are more appropriate and better targeted referrals so that we maintain and don't dilute the capacity of our specialty services to diagnose and treat these people. And I think what I'm most excited about right now is the fact that this infrastructure is going to be amenable to plugging in new therapies as they emerge. So there's new monoclonal antibodies coming out. There's clinical trials for all sorts of potentially disease-modifying therapies. And now we're set up to handle the implementation of these in a systematic way and then eventually roll them out broadly to the health system. And so I think the big takeaway here, if you're going to roll out something like this, is to partner early with your primary care referral sources. This is going to, make them aware that you provide these services, and it's going to help them refine their referral patterns so that you get the most appropriate referrals. You're going to want to designate people within these centers as champions, people who have specific knowledge about these so that they can educate their peers and help drive buy-in on the workflow. And then I would definitely recommend hosting some sort of CME event or grand round so that you can educate people at least annually, because this technology and knowledge in this area is changing on a month-by-month basis. New things are becoming available. And then you want to think about ways to harmonize and embed screening into the routine clinical workflow. Now, I know this is hard because there's a lot of burden on primary care, but think about digital tools. I mean, maybe there's a way to give people a screener in the waiting room while they're waiting to see the provider that would determine whether or not they're experiencing some cognitive issues, and then that could lead to a more formal screening. And then if possible, automate follow-ups. Maybe if you have a system that can complete one of these global cognitive screeners, and if it's below a certain threshold, maybe they move forward to the next step. Now, having a dedicated referral destination, I think, is important because, as I mentioned, this is a very specialized type of diagnostic protocol, and being able to give these monoclonal antibody therapies and advanced therapies really takes a lot of infrastructure. And so I think finding a way to have a designated clinic like our mild cognitive impairment clinic is going to be important. And then you really want to have clear criteria for referrals. And this might create a little bit of burden on the referral side, but I think the payoff is that you're not going to dilute the capacity of the specialty center to handle the appropriate patients. And then you want to be able to track the metrics and outcomes on both sides, because if you're giving better referrals, you're going to have a higher hit rate. And if you're diagnosing earlier, you're going to have more people who can receive the treatment. And so this is a really important process across the board on both sides of the operation. And so I'll go ahead and stop there, and we'll move on to the next section. Thank you.
I am Yasmin Mohideen. I'm a clinical assistant professor in the Department of Neurology at the University of Florida, and I'll be talking about applying the quality improvement methods to assist with gaps in care for patients with early Alzheimer's disease. Some barriers to screening patients for cognitive impairment at the UF primary care clinics that we had identified were time constraints. Appointments at primary care visits are limited, and adding even 2 to 3 minutes for additional testing can be difficult. Additionally, cognitive concerns are often secondary and not brought up at the beginning of a visit. So to have a full conversation, again, in a timely fashion is difficult. There are multiple screening protocols, and the variability in when and how screening is conducted is large across providers and settings. There is an absence of various workflow tools in the EHR. There are paper-based tests, but these may be inconvenient and may be transitioned to a digital alternative. Insufficient training in a busy primary care setting can also limit how standard screenings can be done, along with confusion due to multiple types of screening tools and when to complete them. Other barriers to a timely referral can be delayed access, longer wait times getting into a neurology or a memory clinic appointment. Some referrals can often take months, leading to potentially a delayed diagnosis or care. There can be a limited perceived benefit that even after these long waits, that there was not necessarily an additional actionable result. Some communication gaps with feedback or larger teams with decreased communication, and then patient and caregiver challenges with reluctance to accept or discuss certain cognitive concerns and difficulty coordinating care due to limited caregiver support or transportation. So in the creation of a EHR-based referral to enhance MCI identification, the goal was to implement a referral set to help primary care improve the workflow in identifying and referring these patients. We wanted to have a cognitive screener that is integrated directly into the EHR to help improve patient workflow and allow for this to follow in the patient record. The EHR referral can assist with some decision support to initiate further testing or faster referral into the specialty clinic, along with perhaps different discussions into next steps as far as biomarker testing, imaging, and various clinic referral. We wanted to streamline referrals to auto-populate if possible in the future and reduce variability to improve timeliness into neurology and memory clinics, as well as tracking and accountability to help with feedback and enabling monitoring of screening and referral rates to help identify various useful tools and gaps, and support this with data-driven quality improvement and provider education. The steps and decisions involved in developing the referral set included the steering committee meeting in deciding which cognitive screeners would be most helpful and easiest to complete in a primary care setting. That included potentially an MMSE and the cutoffs for both an MMSE and a MOCA that would help identify those patients, discussing various comorbidities that limit the use of anti-amyloid therapies, including anticoagulation, potentially prior strokes or other comorbidities that would be important to the discussion, and risk management, imaging and biomarker status, such as obtaining a baseline MRI and other information and testing to help expedite that referral and workup after that referral was made. In the order set in EPIC, we decided to add a score for cognitive testing. An MMSE was the preferred choice, a yes/no checkbox for any anticoagulant use and any imaging, optional information for functional status or other potentially important information that would assist, and trying to identify from a primary care setting those individuals that already were interested in amyloid targeting therapies versus a general memory referral. As with any therapy, different challenges included, improving the reason for referral to have something with more definition to help guide where these patients land in MCI clinic. The referral pathway looks like this. It has a area to specifically mention memory, a yes/no for consideration for anti-amyloid treatments, and then the yes/no drop boxes for different screening exams, anticoagulation, and imaging prior to referral. And this information, again, will help to expedite the workup once referred. In our education to primary care clinicians, we decided to review the use of the referral pathway and discuss various areas that would help them as well as patients understand the various conversations that are needed, including advances in different Alzheimer's diagnostics, reviewing how to do some of the cognitive screenings, multiple types of cognitive screenings and which ones may be preferred, and how to properly or accurately add information to the referrals to help get those patients to MCI clinic, in addition to differentiating general memory from patients who are early on. We did a hands-on step-by-step on the referral order, how to pull this up and integrate it potentially into workflows and use of the template, with the goal of improving, clinician confidence in the screening process, having conversations, and ultimately getting more patients into a memory care setting. The QI goals through this process were reviewed and with data feedback to help improve use of the tools. Areas of ongoing improvement included identifying the correct cognitive screening tools. There were inconsistent or multiple types used. With the short visit time, we wanted to improve the type. This is an ongoing process to help identify when to use this and when to have this conversation. We wanted to improve clinical confidence with the new pathways, including the referral and the information. This was done through the CME and hopefully with continuing CME to help improve clinician use. Timeliness. Some delays are persists, but improved use of the referral hopefully gets individuals into clinic faster. Timeliness of the workup prior to the referral will also assist with workup once they obtain their appointment. And then data monitoring, inconsistent, use of the referral or screening rates, and through different dashboards and team meetings, we try to improve this and see how various information and education can help to improve the use of the new pathways. So the key takeaways from this QI project for primary care clinicians were multiple. We wanted to start small and build it up. So we built it with a pilot phase with a small set of providers and trying to increase the amount of individuals that could have access to and use the workflows. We want to integrate screening into routine care and, again, helping identify different cognitive screeners and eventually kind of embedding that into EHR would be something to look forward to. Leveraging these tools to help with a more standard referral, tracking usage to help identify gaps in where we can improve various levels of engagement. We wanted to help a variety of clinicians who see primary care patients identify these individuals, come in early and share the responsibility for screening, follow-up, and discussion, especially in visits that are time constrained. We wanted to build a clear referral pathway to a MCI clinic to help identify those individuals, again, in an early stage, and then using different templates and improving the referral process to help with this decision-making process. And finally, to monitor and report so we can continuously improve how to use various screeners, referral rates, and improve timeliness of a diagnosis to help patients out. Thank you for joining me, and thank you for your time.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by the University of Florida College of Medicine for Physicians. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/RTX860.